Very good morning to all. So since morning, we are hearing lot of CF, DNA, NGS, panel, and is it okay? So talks on molecular. So this is also a molecular, I mean, I will be talking on ALK, ROS and PD-L1 IHC, but it will be mainly a pathology based talk. So we know with the evolving genomic classification, we have n number of molecular alteration. Each histological subtypes have further different molecular, and lung cancer is no longer a single disease. It is comprised of multiple molecular targets, and molecular diagnostics is the way to go. And we can't just stop at the histology and some basic markers. So in the clinic, if we see, there is a typical clinical scenario of a young female non-smoker and a adenocarcinoma histology, which will have a typical biomarker altered NSCLC. So what happens in a typical diagnostic setting when there is a adenocarcinoma? At least we should do EGFR, ALK, ROS, PD-L1. If it is a squamous cell carcinoma, at least a PD-L1. And we can do rest of the markers upfront by NGS. It all depends on what tissue you have, what are the financial constraints, and what is the patient's capacity, affordability. So all this, you can either go by a single gene-based testing or a multiplexing. And in some high risk phenotype of squamous carcinoma also, recommendations say that you can go for this marker. So biomarker testing is very important, and you should be very vigilant when you interpret, because a positivity will determine a marked change in the management. So either you test a biomarker at a DNA level where you use FISH or NGS, at a RNA level where you again use NGS, PCR, and at a protein expression with the help of IHCs. So when now I will be talking on ALK, ROS and PD-L1. So when we see ALK, ROS, it is a fusion or a gene rearrangement, and you can use either of IHC, FISH, PCR, and NGS, and PD-L1 is basically by IHCs. So when you see in diagnostics PD-L1 by IHC, ALK, you do either IHC or FISH, either one is positive, ALK TKI can be given. ROS, IHC is a screening marker which has to be further confirmed with FISH or NGS. And then rest of the markers are definitely with a targeted panel. So why IHC is very important? Because it is very easy. Most of the Indian labs are very comfortable using IHCs. The cost is affordable. And the other most important thing when it comes to lung is that, as we can see, there is a very cellular slide. Do I have a pointer here? Anyways, so there is a very, anyways. Leave it. Okay. My time. Slides. Okay, so we say that NGS, but if you get a tissue like this, which is entirely cellular, but all mesothelial, and just hardly you can see these are the tumor clusters. So this is the test where when I run IHC, I know that this cluster is negative. So I'm very sure that I can actually see the tumor and very comfortable interpreting a IHC. Same holds true with FISH. It is a very sensitive and can be interpreted on a very scanty tumor like this. It is so sometimes we just see a large course, but the neoplastic component is very scanty. But on FISH, you can exactly see what cells you want to see. But it needs a technical expertise, and it like FISH microscope and everything. In RT-PCR, we have multiple fusion partners. So multiplexing with each with different primer designing is not feasible in a diagnostic setting, though it is very sensitive. And NGS, we know it is both RNA, DNA based, and you can know all the fusions, CNVs, SNVs, everything in one go. So coming to the topic, how to interpret and avoid pitfalls. So we all know the success story of ALK. It is a ALK gene rearrangement. EML4 is the most common fusion partner. And whenever there is a fusion, there is activation of the downstream signaling pathway. And ALK inhibitor, crizotinib, ceritinib, lorlatinib, everything is approved. So initially when the ALK testing started, the FISH probe which was FDA approved, and majority of the testing happened in FISH. And we know now is the era when at least IHC positive or FISH positive, we can consider TKI treatment. So what are the issues with the ALK testing? So now we have a very validated and a reliable IHC marker, that is a Ventana D5F3 clone. So what is the issue with this clone is that the protein amount after this alteration is very scanty. So the usual IHC that you use for other tumors is not active in this. And you have to use a modification of protocol. And what we have this Ventana D5F3, it has a different tertiary amplification step. So with this, positivity is fine. You see diffuse strong positivity and anyone can tell this is a positive. But when it comes to borderline cases or challenges, how do you tackle this? So for example, if you get this kind of staining, now this is definitely not strong positive, but any extracellular mucin and all can give this. So this, if this is a signet ring cell, this can also be a false positive, false negative test. Coming to the cell blocks. So this is the tumor and you can see the tumor is negative, but there is a background staining. So that is again an issue. So anything brown is not positive. You have to actually look into what is the, where you are interpreting. So if you get a positive, always there will be, you have to run a negative because you are adding an amplification step here. So if this is positive, this should be dead negative. And apart from it, you have to take a control of positive, non-positive and an appendix. Now why appendix? Because ALK staining is seen in the ganglion cells, but it should be moderate intensity. So an epithelium should be negative. So anything apart from that, if you get variable, your test is not appropriate, you have to rerun the test. For example, this is the core. Now you can see this is not a strong diffuse positivity, but there is a very weak intensity, but diffuse staining. So how do you interpret this? There is heterogeneity, some granular staining. Definitely anyone can say this is something in between, not a positive or a negative. So how do you deal with it? You first see the negative control. It should be dead negative. And second is clinical finding. If this is a scenario, a young patient, female, non-smoker, give it a benefit of doubt, say it is equivocal and ask for a reflex testing by FISH or NGS. Now this is the FISH test. You can see the probe. So probe is the break apart probe. This is the breakpoint region. One side is red and green. If the gene is intact, you will see a yellow dot. Now this is, you can see here yellow dot. Now here we can see there are separate red and green dots here. So this is a, so if these signals are seen in more than 15%, this is ALK gene rearranged. So you can see one fused and one of this is split. This is how a negative will see, all yellow dots. But this is not the usual scenario. Like most of the times you will have this no signals. All depends on how is the fixation of your tissue. So there are interpretation errors in FISH also, because sometimes you can get narrow splits, you can get false negative. There are some gene rearrangements where protein expression is not seen. So all these are the challenges with FISH interpretations. Are there discordant rates? Yes, there are discordant rates. Usually the discordance is IHC is positive and FISH is negative. So, but any positivity is fine. If FISH is negative, ALK is IHC is positive, still you will go ahead with the treatment. And there are various reasons for the discordance. If we see in our ALK FISH, initially we used to do by everything by FISH, but after the introduction of IHC, the rates have gone down of FISH like to a drastic extent. So ROS is again the same. There are a lot of fusion partners, and we now know that crizotinib and entrectinib are all. Again, this is by IHC, FISH, NGS, PCR, all. We have two, coming to ROS, we have two antibodies, D4, D6 and Ventana SP384. As against ALK, not, there will be a variable staining, there will be a heterogeneous pattern. Any positivity is positive. You have to score it as, you have to give positive percentage positivity and what is the nature. Only nuclear is not considered. Rest everything like nuclear, cytoplasmic, everything is positive. So like this, there is positive, but you have to score how many of the percentage are carrying weak staining, moderate and strong, and then you give a H score. So percentage of H score will determine which are actually ROS gene rearranged. So this was 110, but it is negative. It is not a specific antibody because we can see even this normal lung parenchyma macrophages show strong. So before calling anything ROS positive, look where you are interpreting. It is not just the tumor, but rest of the things show positive staining. And even if there are other alterations, you can still see ROS expression. So whenever there is ROS IHC positivity, you have to be vigilant and ask for reflex testing. I will just skip this. So we had compared this D4, D6 and SP384 Ventana antibody clone. We can see if H score more than 250, it is definitely a ROS gene rearrangement. This was the case. This was D4, D6 negative, and you can see a weak staining by SP384. And this was ROS gene rearranged. So point is that, so with the ROS IHC, it is the screening antibody and it is not a predictive marker. Heterogeneous staining pattern, always give a H score. Specificity is there, check the morphology where you are interpreting and check if concomitant alteration is there. If there is EGFR mutation and H score is less than 100, it is basically expression because of the EGFR alteration and not because of the ROS gene rearrangement. So coming to the PD-L1, we know PD-L1 is a very perplexing issue. You have a lot of antibody clones, different platforms, different interpretation criteria. Some you interpret in tumor proportions, some in immune cells. So we can see here, there's a very lot of dependence on pre-analytical. One test, one sample may be positive, other is negative, lot of heterogeneous staining. So last thing, like in lung, we look at the tumor proportionate score. If these are the tumor, how many of the tumor cells are showing, that is important in lung cancer. In TNBCs, if you see, it is the immune score. And in rest of the solid tumors, we look at the combined positive score. You combine everything which is PD-L1. Positive control is a well-fixed tonsillar tissue. If this control is not appropriate, you cannot interpret a PD-L1 on the test. So just this point, like any any membranous staining is important. Any perceptible, any intensity is fine, complete, incomplete is fine. Just that cytoplasmic staining is not considered. Positive is TPS, tumor proportionate score more than 1%. And if it is more than 50%, it is high expression. So this is the normal. So you can see a lot of staining, but tumor cells membranous staining is considered. So it is one of the heterogeneous kind of biomarker. So entire thing is negative, very scanty. Though patchy heterogeneous is common, you have to take entire picture into account. So this is a strong intensity, moderate, any intensity is fine. Necrosis can show, but this is not counting. You have to count in the tumor cells. This is all the cytoplasmic staining which you have to neglect. This is the immune cell staining, neglect. So some do's and don'ts. Charge slides for IHC is must. Tissue should be younger than 3 years. If you send some old block and you get a negative results, you ask for a repeat on a recurrence or a metastasis rather than considering it as negative. At least 100 tumor cells are essential. Any borderline case, take a second opinion. There is a lot of intratumoral heterogeneity. Any positivity you can take into consideration. If it is a metastatic bone decalcified tissue, you will eventually get a negative result. So be aware and repeat on a different tissue. Every time you will have to use a well-fixed tonsillar tissue as a control. To sum up, like in biomarker reporting, always mention the tumor site, histological diagnosis, what is the nature of material use, what is the technique used, platform, antibody clone, anything positivity, just don't say positive, say how much tumor percentage, what intensity. Even if in PD-L1 we say that more than 1% or more than 50% is important, when you actually report, mention how much tumor percentage, like 20 to 30% with what intensity, so that when in retrospect you can easily correlate. Communication is the key. Always there should be a good communication between the oncologist, pathologist, and the lab people, so that you can communicate what type of tissue is it. And if something is asked for NGS and it is not feasible, just communicate. You can do this IHC based markers quickly. And molecular biology results are meaningful only when interpreted in proper morphological correlation. With this, I would like to end my talk. Thank you all. This is our thoracic DMG histopathology lab, and this is our molecular core group. Thank you.
Big thanks to Dr. Trupti for such a comprehensive talk and also for finishing well before time.
Oh, I thought I was. So that is my skill. I thought I was.
Since we have 2 minutes left, I think we can have some questions.
Yes. I really rushed through it. I thought I am finishing. Okay, then if I have time, I can just add on the ROS thing. So ROS, sometimes what happens, any positivity is positive. So no matter if there are 5% with minimal, you give the H score as 5 and you will report it as positive. But for the clinician, I'm just saying that if the patient has a concomitant ALK, EGFR, you will have this kind of ROS expression. If you don't have resource thing, don't just pressurize for fish. I mean, we can do, but it will be, you can start the treatment with the other alteration, because the concurrence of EGFR with ROS is very, very less. Till now, out of many hundreds, I think only 1 or 2 cases we have. And that time the H score is more than 250. It is never, it will be 5 or 10. So on the clones use, if it is a SP384 Ventana, very strong positivity,